All right, I am joined here by Dr. Guy Montgomery, who is first author of the wonderful paper published recently in the International Journal of Clinical and Experimental Hypnosis, entitled Hypnosis at the Crossroads, a primer of the past and visions for the future. Thank you so much, Dr. Montgomery, for joining me here today. My first question for you, could you briefly walk me through this publication as if I were someone who was not familiar with this field?
Okay, yeah. So first off, thank you for inviting me to be here today. It's really very much appreciated. And yeah, this paper is, was now it's published was very much a labor of love. And I've had this appreciation and interest in hypnosis now. Really, you turn around, but now many decades. So that's kind of wild. And the paper really tries to bring people that are unfamiliar to hypnosis kind of into what's going on now. And so when we think about the paper, we kind of think about, well, we broke it up basically into four sections. First, the history of hypnosis. And the history of hypnosis is quite rich. There's a lot going on and a lot happening. And, part of, sometimes how, because of the history of hypnosis, it's how I think about hypnosis is that often the good kid with the bad reputation. In that hypnosis can do so many good things, but historically, there's a lot of, questionable things about there. One of my early memories of hypnosis is I used to be a fan of, now I'm going to really date myself, there was an Abbott and Costello show. That was a comedy show, and it would be on Sunday mornings. And they had, one of the episodes had Bela Lugosi portraying Dracula and using essentially hypnosis to ask his victims to look deeply into his eyes, right? and so, in many ways with hypnosis, you have to overcome that. Right. And so we have to reset what people think about it. And I think, in taking people through the history a bit, we really, help people kind of get a little bit up to date, that it's not all watch swinging and it's not taking control of other people, but rather it's a intervention that's been around for a long time and has really shown a lot of both clinical efficacy and scientific interest, which, makes it a lot of fun to be a researcher in that area.
Yeah, well, thank you so much. I really appreciate learning a little bit about that Abbott and Costello a bit. I'm curious, as you bring up the ways in which you're hoping that this paper will maybe push or nudge the field or shape interest in it. What was your hope for how this paper could perhaps, impact research into clinical hypnosis or experimental hypnosis?
So I'll take you through the other three big sections of
Please,
the
yes.
paper,
Yeah.
and I think that's a perfect lead-in for that. And so the second section talks about hypnosis theory, and it's basically how do we understand this phenomenon of hypnosis. And so we try to approach that covering all the bases and all, historical, theoretical propositions about what hypnosis is, going back to some people even considering it sleep and things like that. And then other, bringing it into more modern times and thinking about things like neo-dissociation theory or cognitive behavioral sociocognitive theories about hypnosis, and then even more, right? And so, that's part one. And then we talk about, well, what is the experimental evidence both supporting what hypnosis is, right? How do we describe this construct and what it can do? And so that would be the third section of the paper. And it really does a really good job of hopefully introducing the reader to what are the, where is the science right now? And what are some future questions like you were just raising? And then thirdly, it's kind of is the clinical section, and it's really, what can it do for us, right? Right. We wouldn't be so interested if it didn't do anything.
Yeah.
And so we discuss a lot of areas where hypnosis has been clinically efficacious for a variety of different concerns, both mental health and physical health. And so getting back to kind of what you were saying is that we want to bring the reader there to say, this is what's gone on in the past. this
Yeah.
is, theoretically how we're thinking about hypnosis, pretty much now. And then how do we test that? And how do we make it better for our patients so that we can bring better improvements, for example, to quality of life? And so if I had one overriding question, I guess, to pose to, new people coming new to this area of study,
Yeah.
coming new to hypnosis, is basically that. Ask questions, right? It's a vibrant field, and no question is wrong or anything like that. But if you don't, ask questions about, well, what is hypnosis? Why do you think that? Why does it work for this person and not that person? And what can we do to help both improve our understanding as well as the clinical application of hypnosis?
Yeah. Well, thank you. That's really inspiring as someone who is coming up in sort of the field of clinical and experimental research within hypnosis. And I'm curious on that note, you bring up the idea of asking questions and hopefully inspiring passionate curiosity amongst people. I'm curious, since you got your start in the field, I'd love to hear if there is a particular topic on which you've sort of changed your mind in the past 30 or 35 years, as all of these questions have been asked. What kind of stokes the flames of your curiosity today?
Those are kind of two things. All
Yeah,
right. So,
okay, yeah.
what have I changed my mind about?
Yeah.
I mentioned theory and how we think about hypnosis. I once heard somebody say, when you're talking like in, either, behavioral or psychological areas,
Mm.
a theory is like a toothbrush. You love your own, but you don't want to use anybody else's. And so I think that my thought is that at one point there was some kind of controversy in the field whether to call like the ability to do hypnosis, right?
Mm.
Whether that should be called hypnotizability. Should it be called hypnotic suggestibility? Should
Right.
it be called hypnotic susceptibility?
Right.
And there were a lot of different reasons, from a theoretical perspective, why you should use different words.
Mm.
So I used to feel strongly it should, for example, be called hypnotic suggestibility. So it's how you respond to the hypnotic suggestions, right?
Right.
And,
Right.
and so, but everybody pretty much uses hypnotizability. So I've given up. It's all right.
Okay.
I'm not going to die on that hill. It's all right, and we can use that word. It has a very general and important understanding across the field, and so okay, and so that's something I think I've changed my mind on. And then I apologize. The second thing you asked was.
Oh, now I'm sort of forgetting. It was just sort of what you're most curious about.
I'm still very curious about how hypnosis works, right?
Mm.
And that we do get these very nice clinical effects in a variety of settings, and it translates very well. But how is it working? And now we're kind of going back into theory again.
Right.
The funny thing is, when I was in graduate school, I thought a lot about expectancy effects, right?
Mm.
And I was very interested in placebo effects. And I had this, there was some, work being done at the time. One theory of how placebos worked was a classical conditioning theory, very much a Pavlovian stimulus substitution model.
Right.
Others, were more, that there was generalized effects, and others were, essentially due to potential brain changes, which, of course, there's brain changes when you're thinking. But, I was more focused on, what, from a psychological perspective, being a psychologist.
Yeah.
And so I was very interested in expectancy effects. The kind of thing, I don't mind the practical joke now and then, as long as nobody gets hurt. And, you ever do that? Like, you've ever helping a buddy move or a friend,
Oh, yeah.
and, you pick up a box, right? It's really not that heavy. It's not that heavy, but you act like it's heavy.
Yeah.
And then you pass it to the next person. They throw it through the roof, right? Because they're observing your behavior, right?
Right.
And almost in like, and it's not through words, right? It's a nonverbal process. and their expectancy is, oh my gosh, that's heavy. I'm going to brace myself. And then they get it, and there's a pillow in it or something, right? And so
Yeah.
I do find that amusing. And so sometimes most people do.
Yeah, yeah,
Anyway,
yeah.
so I was very interested in expectancy and placebo effects, and then I
Mm,
started to think about hypnosis as, placebo is a funny word, like it's pejorative in a lot of ways, but I don't mean that like hypnosis effects are fake, right? They're placebo. I mean that
right,
hypnosis may work many times in the same way that a placebo effect might happen through an expectancy effect. That if
right,
I expect it, then it might happen, right?
right.
And I know with between a lot of labs, some labs show a lot of strong support for expectancy effects. Others
Right,
sometimes don't show a lot of support, and that's okay. That makes it great. And then we get to
right,
think about, well, how did I measure it? How did you measure it? When did you
right.
measure it? How did you ask? What type of question did you ask? Right? And so
Yeah.
there are ways to think about it. Say, oh yeah. And so I still find that extremely interesting, right?
Mm,
And how are we getting to this effect? Because expectancy is a common factor, right? In
right,
whether it's whatever type of psychological intervention that you're
right.
proposing, right? And so I'm no matter whether you're doing hypnosis or a sociocognitive intervention or a cognitive behavioral intervention or a psychodynamic intervention, whatever you're doing, setting those expectancies for beneficial outcomes are common, and they're going to be
Right.
helpful to you and helpful to your patient to achieve their goals. So I like thinking about expectancy effects
Mm.
and how can we use that mechanism to help to both understand what's happening but also to help our patients feel better.
Yeah, well, thank you. That's fascinating. And speaking of expectancy effects, I mean that of course makes me think of Irving Kirsch,
Hmm.
who was your mentor at the University of Connecticut, if I'm not mistaken. Um, I'm curious when thinking about kind of your time in graduate school, working underneath him, what did you learn from him or perhaps other mentors about how to approach being a scientist, how to approach being a psychologist?
um, well, the one word answer is I learned everything from Irving.
Okay.
And so he really was such a wonderful and generous and brilliant person.
Yeah.
And I owe him so much. And so that's the brief answer.
Mm,
Learning about being a scientist, one of the things that I think was super important to learn is that like the outcome of the study is always good, right? It's
mm,
data. The
yeah.
results are important, and that's important information. And you want to design your studies in a way that no matter what happens, you learn something, right? And so if we go way back, that was my master's thesis and dissertation studies with Irving back then. We designed the study so you know are the results going to support a classical conditioning hypothesis, or are they going to explore an expectancy hypothesis or
Mm,
an anxiety reduction hypothesis as what's driving the outcome of lower pain in a placebo study. And so
yeah.
it didn't matter, right? Like we were going to learn something no matter how that study came out. And
Right.
I think that's one of the most valuable things I learned. And then the other thing I learned is, his passion for the science. He loved learning things. And, and we always had a, when the data rolled in, it was always an exciting day. And back then, oh geez, we had to basically have people write on little paper ditto sheet forms, and you had to type, you had to type it in a
Yeah.
program. Oh boy, no red cap or anything back then. So,
Right, right.
but it was always. I learned to be passionate about the science and excited about again asking questions.
Mm, okay, very cool. Well, thank you for that. I'm curious. So, your research started out in his lab studying expectancies, maybe placebo effects, things
Hmm.
like that. And now you are a professor at the Icahn School of Medicine. I'm curious, how has kind of that journey been from where you began your research to now? How did that sort of evolve, and how did you kind of come to pick your current kind of area of study and research?
Um, some of it was luck. Some of it, I started to transition into this. I would like to say it was all planned and I had it all mapped out. No. I finished finishing my dissertation at the University of Connecticut, and I said, well, now what do I do? And I'd pretty, outside of living in Connecticut at that time, I'd always been a New Yorker. And I, said, well, let me see if I can get a postdoc. Because I thought, well, at first, honestly, I don't know how much things have changed or not, probably not much. I thought, oh, I'll get a teaching job, professor, university professor somewhere, like, no problem. Yeah, no, if I was going to, at that time, if I was going to take a university professor teaching job, I think I might have had to go to Nebraska or something, which just didn't, I'm sure Nebraska is wonderful. It just didn't fit my lifestyle at that time. And so, I found a postdoctoral position at Memorial Sloan Kettering. And the reason it worked out was because at that time, some of the investigators there were proposing a classical conditioning mechanism for anticipatory nausea in breast cancer patients when they get chemotherapy. So I'll explain that briefly. So basically, chemotherapy is typically given in cycles, and over time the number of cycles has changed a little bit, and the number of weeks between cycles has changed a little bit. But basically, you're on a schedule. Every few weeks, you're going to get another infusion of chemotherapy, and it makes you feel sick, unfortunately, right? It really, chemotherapy stinks as far as how you feel. And so it turns out it can be like, essentially an unconditioned stimulus, the chemotherapy, that leads to the unconditional response, for example, of, experiencing nausea, right? What happens in many patients is anticipatory nausea. So, I'm making up a patient. You're coming into Sloan Kettering for your chemotherapy appointment. You're driving your car over the George Washington Bridge, or maybe you're a passenger and someone's driving you, and you start to feel sick, right? You start to feel a little nauseous, and it's anticipation of the chemotherapy. And so there's a lot of very, famous anecdotal stories, like at the Children's Hospital St. Jude's, children throwing up at the site of the statue of back in the day because it was a cue, right? And it was a conditioned stimulus, that how it was viewed, and it led to, the response of nausea, right? The conditioned response, the CR. And so they were thinking about that in that way. And that's essentially part of what my dissertation was on, comparing expectancy effects and conditioned learning and the result of a negative outcome, right? And so then we started figuring, we started fiddling around with, what if we had expectancy measures? What if, what if the timing's different? And so that's what got me started in this area. It was really the scientific process, right, of what's the mechanism for the experience of anticipatory nausea in chemotherapy patients that very much got me into the area and got me, that position. And so since then, I'm always thinking about, well, how can we ameliorate that, right? So if it's, if expectancies are contributing to those outcomes, which we showed empirically, well, if we alter the expectancies, we can alter the outcome, right? So we change the expectancies and we get better outcomes. And then one of the ways I wanted to change expectancies was in a non-deceptive way, which was hypnosis, right? So if you do placebo, it's deceptive. And so that's a much harder intervention to swing, right, for many reasons. But if you do it in a non-deceptive manner, you tell people what you're doing, and we're doing a hypnosis intervention, well, then we can manipulate those expectancies.
Okay. Yeah, that's very, very interesting. I'm curious, what are you currently working on right now? Where's your research taking you?
We just finished up a paper on aromatase inhibitors. So aromatase inhibitors are a very popular treatment among breast cancer patients right now. They reduce hormone levels, which is a good thing for people that have had tumors that were hormone responsive, right? So they grow more in a more rich hormone environment. And so if you reduce the hormone levels, you can reduce the risk of a cancer recurrence. Unfortunately, so that's the good side of the drug. The
Yeah.
bad side is you get a lot of what's called arthralgias, or more, you can talk about it as joint pain, right?
Okay.
So you can get a lot of joint pains from this. So we use the hypnosis intervention to reduce joint pain in breast cancer patients, which was a lot of fun. It was a
Wow.
little tricky to run. We had to run a lot of it during COVID.
Oh, okay.
And so things got a little, out of whack here and there,
Right.
but
Right.
we persevered. And so that's happening. And we just published that in, I think, Psychology of Consciousness. So I wanted something in in an APA journal, and for a couple other reasons. So I thought it was fun. And
Very cool.
but so yeah, it was like a 200 patient randomized clinical trial, and so we got very nice effects on the musculoskeletal pain, joint pain, arthralgia, whatever word you want to use, and it was lasting. It lasted for like 6 months. The
Oh,
beneficial
wow.
effects of hypnosis. So that's kind of what now next, like you're saying, what am I thinking about next?
Yeah.
I'd like to do another adaptation, of the hypnosis intervention. One of the things, unfortunately, is, with cancer, people still get very sick, right? So you
Right.
can have people that have metastases and things like that. And so I want to adapt the intervention for patients with metastatic cancer. I want to adapt it in a way that's very convenient for them. Just like we're doing now. I think you're in Texas and I'm in New York. And so we have this, we have more technology available to us that we don't always have to be in the same room for an intervention to happen.
Right.
And so, but I think it's more than just talking on video. I want to, fine tune the intervention, make sure that it's the best it could possibly be for these patients. So that's something, that I'm thinking a lot about. And other things I want to think about, expectancies in other contexts, trying to
Yeah.
branch out into some cardiovascular areas and things like that. And so, trying to put it all together and keep the enterprise running, and it's interesting being a grant-funded researcher right now.
Yeah, it's definitely a difficult time. You mentioned that there's a segue here I want to make, which is that you mentioned, trying to make the experience better for these patients in
Right.
hospitals. And inside this paper, you cited a couple papers that you had co-authored in the past.
Mm-hmm.
One which was a meta-analysis that you and your co-authors conducted in 2000 or published in 2002, finding that adjunctive hypnosis to control surgery-related side effects is incredibly effective, with patients receiving hypnosis faring better than about 90% of patients in the control conditions. You had published a different study that was a randomized control trial with breast biopsy and lumpectomy patients. And in that study, you found that a single 15-minute hypnosis session not only reduced their pain and their nausea and decreased their medication use, but also saved the hospital an average of about like $800 per patient, primarily by shortening the time that was spent in the operating room. And so there are these benefits for patients, seemingly for the healthcare system as a whole. I'm curious, maybe this is more anecdotal, but I'm curious how often hypnosis seems to be used in the surgical room, say at Mount Sinai Hospital, kind of just next to you these days.
Unfortunately, not that often. Yeah, so when I published that clinical trial that we showed not only significant clinical effects for breast cancer surgical patients, but also some not just cost effectiveness, but cost savings, right?
Mm-hmm.
So we saved the institution money. Yeah, I don't want to overstate it, about 772, I think.
Okay.
Close.
Yeah.
You were very close.
Yeah.
And I thought that was my drop the mic moment, right?
Right.
So that everybody's going to be doing it. Yeah. And it's more complicated than that. I didn't realize. And so basically the money doesn't wind up in anybody's pocket, right? So yes, there's an institutional savings, but it's not like that number is added to the surgical department's budget, or that number is added to the anesthesiology department's budget. And so it's tricky, right? So if you, let's say we, let's say we had a pill that did that, right?
Right.
Easy peasy. It would happen. You get the pill. The hospital buys the pill from the manufacturer. The
Yeah.
pill is given to the patient. The patient's insurance pays for the pill. The money goes to the institution. Bang, bang, bang. There's a very clear money trail. In
Right.
this case, there's an initial outlay. So you have to hire a psychologist, for example, to be the deliverer of the intervention all the time. Well, that's a
Yeah.
commitment, right, from the
Right.
department. That's, a decent commitment. And so they're all a little bit hesitant to make that change because they're not seeing that return on investment from a healthcare economics scenario going back right into their budget. So I think that is the problem there.
Right.
And so I didn't want to leave it there. And so I thought, well, if the institutions aren't going to say, oh, let's do this because it's not going to drive essentially healthcare revenue, right? Which they need, right?
Right.
I'm not, saying they don't, they definitely do.
Right.
Then how else can we disseminate this intervention? What else can we do? And
Right.
so we said, heck, let's give it away. All right. And so we created a learning program for using hypnosis to control pain with cancer patients. And so what it is, it's a blended learning approach that includes an online portion for learning that's self-paced and you can do and follow the modules. It even has some like decision tree stuff, kind of stuff where if you do one thing, you get it's like you're making your own story kind of thing.
Right.
And,
Yeah.
So that's a lot of fun, and then it has a live workshop component, right? And so where the trainees interact with myself and the other faculty on the project, and we train them to use hypnosis with their own patients. And so so that's how I'm trying to I'm trying to get around that. Well, it's not going to be picked up for economic reasons. Well, maybe I can get it picked up just by giving it away and saying, here's what we did, here's how you can do it, and here's how you can help your patients.
That's a wonderful idea. I'm curious, does it feel like this is making some inroads into the medical community? Where do you see interest kind of potentially existing within sort of healthcare providers or patients?
A lot of patients can get interested because now they have access to so much information.
Yeah.
And so I think the patients in a lot of ways are the driving factor. That, I'm not, this is no judgment. I think a lot of our medical centers are facing tight economic times.
Yeah.
And so, for them to say, oh, we're going to invest in these new programs right now, without knowing it was going to pay off for them is dangerous, right? So they have to accomplish their primary missions. And, and that's, and that's okay, right? And so, but I think the patients often drive a lot of the interest and essentially consumer interest. And they'll find people like myself and say, hey, I'm going for surgery. Would you consider doing an intervention for me? Or, and so I think that's what's keeping hypnosis alive and well, is that the patient interest in the technique. And it's the funniest thing, I very fortunately, at different times in my career, I've done different media events and things like that. And if, it's because I was doing hypnosis. If I was doing, relaxation training with guided imagery, it wouldn't, they wouldn't call me up, you know what I mean? I would not be on the Good Morning America to do that. And so it's, I think, it's out there, it gets people's interest, and they're like, well, how can we use this to help? And I think that's the neatest part of it, is working with people. So I think a lot of my personal opinion, a lot of the drive for, disseminating hypnosis comes from patient interest.
Yeah, that makes sense.
And one of the lovely things is that it could be somebody with, test anxiety in college.
Right.
It could be somebody facing cancer. It could be somebody that is worried about agoraphobia. It could be somebody, so this hypnosis is a technique that's highly malleable to different situations, right? And that's where, we can, have a real strong impact. And it's like any other psychotherapeutic technique, is that you have to explain it to your patient. You have to talk with them. You have to say, why are we doing this? Why do you think it's a good idea? You have to have rapport and a bond, right? And so it's no different. So I think that's important. I always counsel patients in that, you know, like if they're experiencing some problem, let's call it problem X, look for a provider that works on problem X, right? And then you can see if they use hypnosis, right? And so, you know, but you want somebody, as in always, whether it's a medical intervention, you know, psychological services, you want people that are licensed in your state, right, as providers, and people that have experience in helping people with the kind of problem that you're dealing with.
Yeah. Well, thank you so much for joining me. Before we end today, I don't want to take up too much of your time. Is there anything that I did not ask that you'd like to use this forum to share?
Let me give me I wasn't ready for that question.
Oh, sorry. Yeah. Well, we could just sort of end there.
Yeah,
Or,
no,
you know,
no.
skip
But
ahead.
like, what else do you want to know? I have a few minutes. My 4 o'clock was canceled. We're good.
Oh, perfect. Okay. Great. Well, yeah, I guess I'm curious about your sort of point of view, maybe your optimism or pessimism on sort of this idea of a patient driven or consumer driven sort of shift in the field, where maybe there will be this re-embrace or this
I'm
newfound
optimistic.
openness.
Yeah,
Yeah.
I'm optimistic about hypnosis, and both as an area of study and as a clinical intervention, because like a lot of other things, it waxes and wanes over time, right? So there were times of very high interest, and in our past, you know, I was mentioning the history of hypnosis goes back hundreds of years now at this point.
Right.
And then there were lulls, and there's times when people, you know, hypnosis, you know, people are afraid of it. Oh, hypnosis, right? And then there's times when I'm like, oh, that's pretty cool. I'd like to try that. I know my friend used hypnosis to help with their weight loss program, right, or whatever. And so it's, you know, I think that I am optimistic, and I think, and part of it is because consumers aren't beholden to their provider to come up with options for treatment anymore, right? And we know that's a fact because of all the pharmaceutical commercials on television, right? So it's if you know, so the pharmaceutical companies many times rely on the patient saying, "Hey, I want that," right? And so I think patients are getting more of a voice in their care and saying that, all right, hey, I'd like to try that. And one of the beauties of hypnosis is there's not really a downside, right? It's for, you know, 99.9% of the patients, it's kind of pleasant, kind of a nice thing.
Right.
And when you're working with a skilled provider, it can be adapted to fit what you want, right? You know, if I'm, you know, working with an individual patient, one of the things is like, okay, we're going to work on problem X, but to get there, let's start with a relaxing scene. What do you like? Do you like going to the beach? Do you like going to the mountains? And do you like just floating on a cloud, or being in a large bed with a really fluffy comforter and tucking in? You know, what is it that you like that I can bring to you and help you with this whole experience? And so I love the creativity of it.
Yeah.
And then always thinking in the back of my head, right, okay, we're going to get them there. Then we're going to start to gently manage expectations about outcomes. And then I'm going to provide suggestions that are consistent with the patient goals.
Yeah. Okay. Well, I really appreciate that. Thank you so much for joining me today. Really enjoyed our conversation, and hopefully we can get the word out about this wonderful paper and get the word out about hypnosis in general.
Yes. So, yeah, thank you. Thanks for setting this up.
Yeah.
You're really very pleasant to talk to. I'd love to do it again. And if you have, you know, you or others have any interest, the hypnosis training program is really, we've done a few, so we've kind of improved it each time. It's kind of nice. And so it's called HCAP.
Okay.
So if you like Google my name and HCAP, or if you can't find it, let
Yeah.
me know, and I'll send you a link, and you
Okay.
sign up,
Perfect.
and
Yeah.
you also get, I don't know if you need them yet, but you also get free CEs. So for anyone that needs CEs, they're free, and usually pretty much most people like the course, which is very reinforcing.
That's wonderful. Please do share the link with me, and it's
Sure.
HCAP. Is that correct?
Yeah, I'll send you the link. You'll see it.
Okay,
And
perfect. Yeah, because maybe we can push it out with this video